Well, thank you, everyone, for the opportunity to speak today. I'm Susan Zbikowski from Alere Wellbeing, which is formerly known as Free and Clear. And I want to tell you a little bit about my role in the organization and then this project. So I'm the Senior Vice President of Clinical and Behavioral Sciences at Alere Wellbeing, which means I oversee the company's research program, as well as two services that we provide, which is healthcare provider training and education, as well as program evaluation services. Alere Wellbeing is based in Seattle, Washington, and owned by a company named Alere. We were acquired in 2009. Prior to that, we were a standalone private company, and then prior to that, part of Group Health Cooperative. And our history is as a service provider primarily of tobacco dependence treatment programs. However, in 2009, we rolled out our obesity management program, which is the Mind and Body program. So we have a long history of treating tobacco dependence. So one of the single greatest challenges that we see as a service provider is that in spite of delivering treatments, that the majority of our patients or participants relapse after successfully quitting. So this is a challenge. And what I'd like to do today is to tell you about a possible solution for addressing one of the primary causes of relapse that we've seen in treatment, which is patients expressing concerns about weight gain in treatment. And that solution is the Way to Quit program, and we've done a trial on it. I'm going to tell you a little bit more about that. And then after telling you about the trial, what I want to do is tell you about the overall trends and implications for what I'm seeing, how we're informing future treatment designs. So why should we address weight concerns of smokers? Well, first of all, the average smoker gains between 8 and 15 pounds in treatment, and weight concerns are highly prevalent. 25% of men and about 50% of women express weight concerns when you ask about that. We actually see even higher rates of weight concerns among individuals who are calling state tobacco quit lines. In addition, weight concerns have been associated with derailing quit attempts and quit success. What we see is that individuals with weight concerns are far less likely to actually make a quit attempt, and that when they do make quit attempts, it may prevent them from successfully adhering to treatment, and it can actually lead to full-blown relapse. Now, the approach to addressing weight concerns is somewhat complex, and there's been a high degree of controversy in the literature as to whether or not somebody who's trying to quit tobacco should also try to lose weight. And so that's been ill-advised, and we have a very different approach in the Way to Quit trial. So the Way to Quit study was a randomized controlled trial conducted in the context of the Oklahoma helpline. This was one of the many helplines that Alere Wellbeing operated. So we were the service provider for this helpline, and individuals from the helpline were identified, and after identified and consenting, randomized to one of two different conditions, and I'll tell you more about those. But basically, there's standard of care, which was a 5-call program, versus an enhanced weight concern intervention that had 8 calls. And then after randomization, 6 months later, we assessed outcomes to determine quit status and many other measures. So this was our methodology. Basically, individuals calling the Oklahoma helpline were assessed on 2 key measures, that is their BMI, height and weight were measured to calculate BMI, and then also their weight concerns. The reason why we assessed BMI was that we didn't want to have individuals in the study who were underweight. So we wanted either normal weight, overweight, or obese, and then everyone had to have health concerns expressed. Those individuals who were interested and eligible were then transferred to a coach, randomized, and then we began services immediately. We had several hypotheses in this study. First of all, we hypothesized that we would improve cessation outcomes, that because of improving cessation outcomes, patients should be more satisfied with their treatment, and then that we would reduce weight gain or have weight gain attenuation, and then lastly that we would also reduce weight concerns. So let me now tell you about the 2 different treatments. All the services were provided by Alere Wellbeing. Again, we were the service provider for the Oklahoma helpline. And the standard treatment is the Oklahoma helpline service, which includes, as you see up here, participants receiving up to 5 calls. They received self-help materials, medication information, and in many cases, also direct provision of nicotine replacement products. About approximately 2/3 of individuals were eligible to receive medications in the study. And then in addition to that, they had access to a web coach application which had patient education materials, interactive tools, and social forums. And then they could call in for support at any time that they wanted. So there were proactive calls and reactive calls. The foundation to this program has been tested in numerous clinical trials. So the Quit for Life program has been demonstrated effective in trials, as well as the Quitline services. It is consistent with the Public Health Services guidelines for treating tobacco dependence. The program is based in social cognitive theory, and the coaches in the program are using cognitive behavioral therapy techniques, where they're trying to teach participants very practical skills about how to plan and to address their quitting process. So they're assisting them with establishing a quit date, coming up with a quit plan, and then developing practical skills for coping in different situations. Now for the way to quit intervention, we've made modifications to the standard of care. Where we turned to in doing this was going to the literature, and that there was published work done by Perkins and Levine at the University of Pittsburgh, where they had demonstrated with an intensive trial that they could, in fact, affect weight concerns and improve outcomes. And so what we did is we adapted that intensive in-person protocol, which was approximately 16 sessions in person, and that was just not realistic in the context of a service. So what we did was to look at that protocol, make adaptations, and incorporate it into an 8-call program. And what you can see here is the timing of different events. Basically, the standard treatment begins again with somebody getting their first call. They usually then receive a quit date call right around their quit date. 1 week later, everyone receives a quit date follow-up, and then the additional quit calls are usually about 3 weeks later, spaced every 3 weeks. And what we did is to interject 3 additional calls here, which were conducted with a weight concerns coach. So individuals in the weight concerns intervention received calls both from a tobacco cessation quit coach as well as a weight concerns coach. So now I want to tell you a little bit about what the intervention focused on. There were 6 components. Coaches were looking at addressing maladaptive beliefs about weight and concerns that the participant may have. Then they looked at the motivation and confidence in quitting, and this was mentioned in the previous talks as being very important. And then there was an important focus on accepting some weight gain during the normal quitting process, that is normalizing that weight gain is typical. And then most importantly, discouraging any dietary restrictions. So we did not want participants dieting in the intervention. And instead, we focused on proactive behaviors such as healthy eating, eating healthy snacks, eating a healthy diet, and then increasing physical activity. So let me tell you a little bit about the participants and then the results. So the majority of the participants in this trial were women, about 80%, and they were 80% Caucasian. The other ethnic groups represented were African American and Native American, which is very consistent with the Oklahoma population. And all the participants had weight concerns, and that is by design as part of the screening process. And then, interestingly, about 2/3 had expressed that they believe that they were overweight, and in the past that they had had significant weight gain associated with their quit attempts, about 17 pounds. And 40% in the past had reported that they dieted when quitting, and that they had a high expectation of weight gain. They thought they would gain about 20 pounds and a low tolerance for accepting any weight gain. And you can see only 60% were willing to gain 10 pounds before they indicated that they would relapse again. So now turning to the results, again, the hypotheses, we had 2 hypotheses around cessation. One would be that we'd improve overall satisfaction with service, and then also actually improve cessation outcomes. So you can see here that we saw about a 3 percentage point increase in satisfaction in those individuals receiving the weight concern intervention. Although it's 3% higher, we did not see this as statistically significant. Likewise, we looked at cessation outcomes at 6 months, and we report 2 measures here in the slide, 7-day point prevalence and 30-day prolonged abstinence. And these are both among the individuals who responded to the survey at the follow-up. And again, regardless of the measure, we see about a 3.5 percentage point increase in cessation rates. So 3.5 5% more of the individuals being quit in the intervention group than the control group. Despite this increase, which we would consider to be clinically significant as well as significant from a public health standpoint, it was not statistically significant. Where we did see changes had to do with respect to weight concerns and changes in weight. So on this slide, we're now looking at people indicating whether or not their weight had stayed the same, changed, and whether it was increased or decreased. And you can see here that the intervention group was far more likely to endure, or less likely to endorse that they gained weight compared to individuals in the control group, and this was statistically significant. Then we looked at two different ways of assessing actual weight change. And so one was perceived self-report of the number of pounds of change, and then the other one is calculating from baseline to follow up what were the self-reported weights. So the self-reported weight at baseline, the self-reported weight at follow-up. And you can see in both metrics that we see that the intervention group was more likely to report that they lost weight compared to the control group. That was statistically significant when we looked at perceived reported number of pounds of change compared to actual calculated changes in self-reported weight, which was marginally significant. Then when we look at weight concerns, we see that the intervention had an effect for reducing weight concerns, that those individuals who were randomized to the weight concern intervention had a significant decrease in their weight concerns after going through the study. Some other results that I want to report is that we also looked at these effects by age and gender and tobacco status at baseline and found no differences. And this was a little bit of interest to us because in the original work that was done by some researchers, they had found gender effects, and so we did not see a gender effect. We did see a stronger effect for Caucasians in the study, and then also individuals with higher self-efficacy, and an interesting finding with respect to smokers who had diabetes. And in fact, in our sub-analyses, we found that there were significantly higher quit outcomes for smokers with diabetes who received the intervention compared to the control, and also statistically significant changes in weight gain attenuation. We actually saw a doubling of quit rates, and we saw about a 16-pound difference between the intervention and control among people with diabetes. I'm going to come back to this as we talk about future directions. So now I want to turn to kind of from a scientific perspective, my assessment of the study, and then also what I think are the overall trends in terms of where interventions are going. So from a scientific perspective, I'm very excited about this study because it shows that we were able to successfully translate and adapt a very intensive in-person program into a real-world practice, and that these services are widely available now across the United States. If you do not know, every single state in the U.S. has a tobacco quit line. And so there is great access now available to smokers in all the states. And then that we were able to successfully address two concerns. So we're addressing the concern of tobacco cessation as well as weight concerns. So integrating two concerns into one treatment. And that we were able to, from a product perspective, scale this. So this has now been implemented as a standard product that Alere Wellbeing offers to our clients, and we're starting to have adoption of this product by clients. And that we continue to see that state quit lines are a great environment for testing concepts before they become ongoing practice. Now I want to talk briefly about what are the trends that I'm seeing in terms of where treatments are going and just the complexity of addressing behaviors. So, the first theme is that there is a trend towards having to address and target different populations. This came up in the previous talk. And so, one thing I am seeing that's really important is that you really do need to understand whether or not your standard treatments work for all populations. It does not necessarily mean that every single treatment has to be targeted to a population. And in fact, it's critically important to not consider groups to be homogeneous. And what Rod just mentioned in his previous talk was that, in fact, you need to personalize, you need to individualize treatments, and it's very important to think about the unique needs of the individual and the population that they may represent. But this is definitely a trend that we do need to make sure that treatments are effective for all populations. Then we're also seeing that treating tobacco dependence and treating other behaviors, they're complex. It is not just about necessarily treating that one problem, and that we see individuals presenting other problems. Depression is widely reported among smokers. Weight concerns is very widely reported, and this means that you have to design interventions that address perhaps maybe more than the presenting problem or the key issue that you're trying to change. And then the other thing that I've seen in the 10 years that I've been at Alere Wellbeing doing research and then tracking this as a scientist is that interventions are getting more and more complicated. So Alere Wellbeing, when we were part of Group Health Cooperative, was delivering a phone-based intervention with self-help materials. Then in the 90s, medications became recommended and proven to be effective, so that had to be incorporated. And then there's been demand for web-based applications, which we've incorporated in 2006. And now the newest trend is, of course, mobile applications and text-based solutions, and we're actually in the process of rolling that out in 2012. So what we don't know yet as a scientific community is if these different interventions are truly all independently effective or in combination improving outcomes. But what I do think is important is that we need to provide these different tools and modalities so that we can meet the demand of the consumer, the individual, because they have preferences for how they receive treatment. And if we just do it one way, it may not meet the ways, and that could prevent ultimate success. So briefly, future directions are that we are going to follow up on obesity, and that we're interested in looking at whether cessation outcomes are equal across the BMI spectrum of overweight, normal weight, and obese. We are interested in following up on this finding of the effect for smokers with diabetes and seeing if we can replicate this in a larger randomized trial. We're also interested in looking specifically at the population of smokers with diabetes, and do they need a unique treatment? Meaning, should it be something that's more enhanced, something that perhaps incorporates more of these mind and body elements of lifestyle issues, of addressing weight and diet and being more active, and doing this on a very intensive basis? And then lastly, we are looking at multiple behaviors. We have a grant that has received a very good score, but we're waiting for funding. And if that were to get funded, we will now look at this more complex issue of whether somebody should quit first and then lose weight, or is it acceptable and effective to actually have somebody do it simultaneously. So we will look at the multiple behavior issue and not just weight concerns, but actual weight loss. So I'd like to now acknowledge the collaborating institutions. In addition to Alere Wellbeing, it included the Oklahoma Tobacco Settlement Endowment Trust and the Oklahoma State Department, 2 divisions, Tobacco Use Prevention and Chronic Disease, and the University of Oklahoma. The funders included the Department of Health and TSET. And then here are the investigators on the study, including researchers at Alere Wellbeing, and Tim McAfee, who used to be at Alere Wellbeing but now is at the CDC, and then Dr. Levine at the University of Pittsburgh, and Laura Beebe. And I would in particular like to acknowledge Dr. Terry Bush, who was the lead investigator on this study. So this is her research. Thank you so much for the opportunity to tell you about this.
Susan, you mentioned that you had 2 separate coaches for the calls, one for tobacco and one for weight. Was there a particular reason for that, and would you do it the same, or are you thinking of changing to one coach? Could you talk about that?
Yeah, sure. So the rationale for doing that was that we believe in a model of specialist, and that you could go to a general model of having a general health coach, but we've seen in our 25 years of tobacco dependence treatment the benefit of having people who are specialized in tobacco dependence treatment. And so our philosophy was to do the same with weight concerns. And so the coach there was somebody who had a nutrition background. We also, as an organization, had coaches in our staff who were nutritionists because we had a bariatric support program and an in-person group weight loss program. So we were able to think about, should we train our coaches to do this, the quick coaches, or should we just incorporate the other staff that we had? So it definitely added challenges for how we had to do the intervention, and at this point, we do continue to do it this way.
I really enjoy all of the work that you're doing to engage patients. And as a patient advocate and advisor, that's dear to my heart. All of you gave great presentations. And I had a question for Paul. I'm not going to try to pronounce your last name. And on the slide that showed the collaborative care diagram with the triangle,
right,
you have the patient in the center.
Yes.
And as a patient advocate, I use the term patient and family-centered care.
Mm-hmm.
And I was wondering if you were to have that patient and family in the center of your triangle, do you think maybe the spousal depression might have been identified sooner?
Yeah, I think so, especially if there were shared visits and bringing the family member in more readily. I think that that would be an option, and perhaps by having that broader view.
Mm-hmm.
But some patients would prefer to just deal with things on their own without having the family member there. But
yeah,
absolutely, I think that would be a great idea. And in fact, we did deal with family members, not by bringing them in, but recognizing that they were often helping to make these things happen in the home. Absolutely.
Thanks.
Sure.
So, and this is Scott Pritchard. I represent the state of Washington. We have 120,000 employees, about 250,000 covered lives that live inside the state. So a question for Paul. Paul, I want to congratulate you on the team approach, a great model.
Thanks, Scott.
With so many folks that we have insured in this area, how do our employees and their families access this excellent model? And then a follow-up question, do you have plans to spread this model, and what would that look like?
Great. Thank you very much for the question. And I didn't have enough time, so this is perfect because I was just telling Rod that I wish I'd had more time to speak to that. So you're a plant. Thank you. Basically, we're implementing this in the province of Alberta right now. We just signed a contract 2 weeks ago with a large healthcare organization here in Seattle. We have a 1-year contract, and they have hired nurses to run team care. And I do know that they are working with 4 insurance companies to underwrite some of the costs of this, because the bottom line here is it is cost effective, $600 savings after 2 years. Because if you think of what we found when we've done our randomized control trials, if you follow people for 1 year, that's fine. But if you follow people for an extra year and look at healthcare costs, that's when you start to see the difference. Not in that first year when you're spending money to implement the intervention. So it saves $600, and if you use Medicare benefits, it's $54 per nursing visit, up to 10 visits that you can get for diabetes care. I'm just learning all this here. So that could be a potential of $1,100 that you could sort of through offset and the costs. So I don't know if that's answering your question, but we just did a national training. So this is one of the studies, and I know we're short on time here, but I'll just tell you, we had a platform in place. We have a training institute at the University of Washington. So basically what we had is we got the publication out December 30th. 2 weeks ago, we did a national training, Overflow, here in Seattle at Bell Harbor, and are training people around the country. Plus, we got this contract all within 9 months. Someone said that the research cycle is usually about 17 years from that time of a research study till full implementation. And we've worked hard to make sure we had all the materials on the web and are using marketing principles and all kinds of other things to get the word out. And comments like yours and questions like yours help too. Thanks.
So mine is sort of a follow-up question to Scott's. I see a lot of similarities between this model and what is now being referred to as a patient-centered medical home model. But I understand, or I heard, that yours is really focused on a registry of those with chronic disease. Is that the model that you're planning to?
Right, good question. And that would have also been something I would have talked about if I'd had more time, but thank you. If you go to our website, teamcarehealth.org, in the top left is our tagline, and it says something like, better care for the medical home. So absolutely, this is built for the medical home. That's why we got this contract with this healthcare organization. They said, we want to get the medical, they're doing a collaborative nationally, and they said, we need to get this. This is a solution for a medical home because it leverages one case manager. It's a team approach. It's basically, I mean, we've been working at group health, we've been working with Ed, so, policy and medical home is just sort of what's actualized, but we've been sort of building interventions to do that for years. So, accountable care, incentive payments, all of that, it ties right into that. Thank you for that question.
So, anyone have a question? I think this will be the last one, and we'll take a break.
As a follow-up to the last question, implementation and adaption of a lot of these programs requires funding, and the key is showing these cost savings. Are your statistics available, and so that we can use those?
We're very aware of that and how policymakers and administrators and the decision makers need to see those data. We do have a paper in review or maybe in press, I don't recall. We're writing a flurry of papers, so we definitely have a really nice, I gave you the bullet points, but we have a nice paper that looks at quality of life measures, depression-free days, costs, and the cost savings. So that will be coming out, and if you contacted me, I could talk to my team, and maybe we could give you a little more information if you'd like to have that. Yeah, thank you.